Welcome, everyone. Today, I'm tackling a subject that hits close to home for many prostate cancer survivors, dealing with erectile dysfunction after a radical prostatectomy. If you're here, you're not alone. Let's dive right in. First things first. It's important to understand that ED after prostate surgery is common. Radical prostatectomy is one of the most commonly used treatments in men with prostate cancer. Despite the adequate oncological results, erectile dysfunction remains relevant among post-surgery complications. According to the publications, the prevalence of ED after surgery is between 14 to 90%. This wide range is due to the definition of ED used, the type of population studied, and how the data was collected. It happens because the nerves and blood vessels surrounding the prostate can be affected during the procedure. Based on the pathophysiology of the ED can be related to arterial insufficiency or venoclusive dysfunction. In the particular case of prostate surgery, structural changes occur in the penile erectile tissue due to direct or indirect damage to the pelvic nerves, which leads to atrophy and fibrosis of the erectile tissue. The consequences of these structural changes in the erectile tissue are the development of veno-occlusive dysfunction and an increase in venous leak, which is the pathophysiological basis that explains the development of ED after radical prostatectomy. According to the evidence, in post-surgery, all patients have an increase in collagen deposition or fibrosis in the erectile tissue and a decrease in smooth muscle and elastic fibers in the corpora cavernosa. These findings are observed 2 months after surgery and progress significantly after 12 months after surgery. For this reason, the post-surgical time is critical to avoid the development of veno-occlusive dysfunction. We reported a higher incidence of this venous leak at a longer time after surgery, with a prevalence of 10% at 4 months, 35% between 8 to 12 months, and 50% after 12 months post-surgery. This veno-occlusive dysfunction, or venous leak phenomenon, would occur much earlier in men who did not have nerve-sparing surgery. We reported that the incidence of venous leak in this group of patients who had RP without nerve sparing was 17% at 3 months and 75% at 6 months after surgery, in comparison to 0% at 3 months and 7% to 11% at 6 months when one or both sides of the nerves were preserved during surgery. We know that risk factors associated with a higher incidence of veno-occlusive dysfunction and ED after surgery are age, baseline erectile function, nerve sparing during surgery, and the presence of comorbidities. We know that older age, over 60, the presence of ED before surgery, surgeries without nerve sparing, and the presence of 2 or more comorbidities including diabetes, sleep apnea, coronary artery disease, dyslipidemia, and hypertension, increasing the chances of having ED after surgery. The good news is, there are several ways to manage and even overcome this challenge. Number 1 on the list is patience. Recovery takes time. This is a slow process. A slow recovery that it can take up to 2 years post-surgery. But you need erections as soon as possible after radical prostatectomy because if you do not use it, meaning no erections, you will lose it, meaning permanent ED. Your body has been through a lot, and it needs time to heal. Don't be too hard on yourself if things aren't back to normal right away. You need to know that erections will preserve the erectile tissue of the penis, and you need just erections enough for penetration to maintain this erectile tissue in a good shape. And obviously more is better. We always recommend at least 3 erections per week after surgery to preserve the penile erectile tissue. Next, let's talk about medications and penile rehab after surgery. Penile rehab is defined as the use of any drug or device to maximize erectile function recovery after surgery. The objective is to limit structural alterations, prevent veno-occlusive dysfunction development, and maximize the chances of a man returning to his pre-op erectile function level. We know that the worst ED is just after surgery, 1 to 3 months, and the final recovery is 18 to 24 months after radical prostatectomy. PDE5 inhibitors like Viagra, Cialis, and Levitra can be effective. These drugs help increase blood flow to the penis and are often the first line of treatment. PDE5 inhibitors preserves the erectile tissue of the penis, preventing structural alterations of the endothelium at the arterial level and the smooth muscle of the corpora cavernosa, and preserving its relaxation properties. They have an excellent safety profile and are convenient for patients. However, for some patients, these medications can be expensive, and there is a high discontinuation rate in the long term, with 32% of men not continuing to take these medications 2 months after surgery and up to 39% 6 months after radical prostatectomy. This information is critical since it can impact the results of the recovery of erectile function in our patients, and it is essential to highlight treatment adherence to maximize the benefits. Always consult your doctor to find the best option for you. If medications aren't cutting it, you might consider vacuum erection devices. These are external pumps that help draw blood into the penis. They can be a bit mechanical, but many men find them very effective. Vacuum devices or penile pumps are not used in penile rehab program. It is used especially to preserve the length of the penis after surgery. They are easy to use and non-invasive. The reason for this is that the erections produced by vacuum pumps are a combination of arterial and venous blood and with a lower level of oxygen saturation, which would be inappropriate for the preservation and maintenance of the smooth muscles of the penile erectile tissue compared to the use of PDE5 inhibitors such as Viagra or Cialis and injection therapy, which generate erections where the blood comes 100% from the arterial side with a high level of oxygen. Another option is penile injections. Yes, I know, the idea can be daunting, but these injections can produce a strong erection by directly delivering medication. It's worth discussing this option with your healthcare provider. Injection therapy is used for those who do not respond to PDE5 inhibitors. ICI therapy is a well-known and effective erectogenic treatment, but some patients consider it invasive. The training to know about injection therapy is critical. You need to know about how to prepare the medication, how to inject your penis, and you need to know about the safety. It is not painful. Most of the patient describe it as a mosquito bite. In a scale 1 to 10, 1 no pain, and to a really bad pain. Most of the patients describe the injections as 2 or 3 in that scale. We have only one concern regarding injection therapy, and it is prolonged erections. You need to know what to do in case you have an erections lasting more than 2 hours. This is dangerous and it can kill your penis if this erection lasts more than 6 hours. In our training, we review all the safety steps, what to do in case this happens, and the most important, we need to know the right dose that you need to get in erections, that it is at least good enough for penetration for less than 1 hour. Never increase the injection dose by yourself. This is the reason number 1 you got a prolonged erection. At our sexual and reproductive medicine program, our penile rehab after radical prostatectomy ideally consists of a pre-surgical evaluation. Patients are instructed to start daily low doses, nightly, of PDE5 inhibitors 2 weeks before and continue 2 weeks after surgery. Once the patient can resume sexual activities, patients maintain their daily doses, but once a week or up to 3 times a week, they should take a full dose of PDE5 inhibitors and try to have erections. At 6 weeks after surgery, the patients are evaluated. If the patient reports having functional erections, which are at least enough to penetrate, the patient continues with the same scheme. If not, the patients begin with ICI therapies once or up to 3 times a week, continuing with the daily low dose of PDE5 inhibitors. All patients who begin ICI therapy are instructed to start again with high doses of PDE5 inhibitors 12 months after surgery, monthly, to evaluate whether they can generate functional erections for penetrative sexual activities, and so the patient can stop the ICI and continue with oral medications. Patients are evaluated every 3 months post-surgery during the first year, every 6 months in the second year, and annually after that. If the patient shows concern about the length of the penis, we use the vacuum device to generate erections and thus elongate the penis in a standardized protocol at our institution. And don't forget the power of a healthy lifestyle. Regular exercise, a balanced diet, and avoiding smoking and excessive alcohol can improve your overall health and help with ED. Mental health is just as important. Stress, anxiety, and depression can all contribute to ED. Don't hesitate to seek counseling or therapy. Lastly, communicate with your partner. Open, honest conversations can significantly reduce the stress and anxiety surrounding ED. Your partner can be your biggest ally in this journey. To sum it up, dealing with erectile dysfunction post-prostatectomy is challenging, but there's hope. With patience, medical assistance, lifestyle changes, and open communication, you can find a path to recovery. Thank you for watching. And remember, you're not alone in this. Stay strong and take it one day at a time. Until next time, take care.